Hello and welcome to the Women's Health Lecture. I'm actually doing this from work, so you might hear some odd noises like a phone ringing or some background noise. Just hopefully it won't get too disruptive. Apologize in advance. But this is the women's health topic, and we'll go over not obviously all things related to women's health, but certainly some things focusing on the hormonal manipulations that are generally associated with the female gender. And we've talked about a number of things in relation to women's specific health throughout the year, but this will be more of a focus on those specific hormone manipulation strategies for certain things. So we'll start out with contraceptives. And contraceptives are probably one of the most commonly prescribed medications on the planet, and we'll spend a fair amount of slides going through them because there's certainly a lot of information out there, and I think a lot of good information to know for any prescriber or healthcare professional. So there's a lot of women, obviously, throughout the world that take oral contraceptives. It's one of the most reliable and easy to obtain forms of contraception out there, and when taken correctly, basically have a 0.1% chance of pregnancy. However, with typical use that's seen in the general population, people tend to have about an 8% chance of getting pregnant when taking the birth control for a year. This is mostly due to things like missed pills and failure to resume therapy appropriately after, for example, taking the placebo pack or skipping the placebo pack and not remembering when to restart. There's lots of ways that companies market their products, so specifically with packs that have calendar days on them and things like that, but depending on how reliable the system the patient has, may or may not end up missing things regardless of that. There are other options such as depot injections and IUDs, and other topical products like rings and patches, which actually have a topical application but have systemic hormones that absorb systemically, I should say. So there are other options for people that might have issues or difficulty remembering to take a pill every day. However, there's other problems involved, especially with like a ring or a patch. You have to remember to replace it. You have to remember to do it on a schedule. And so some people will actually find taking a pill every day much easier to remember than doing something like taking a patch or a ring that might get forgotten about. Generally speaking, contraceptives are usually referred to as combined oral contraceptives, or COCs, or OCs as I've abbreviated here, but most of them contain both a progestin and an estrogen component. And when these products first came out, I've actually been around for quite a while. The original oral contraceptives started in the 1960s. And they had a significantly higher amount of hormone active product than they do now. So the doses come down substantially, and found that we can give much lower doses of hormone and still have a very effective end product. If you want to compare contraceptive types with typical use and correct use, so for example, if somebody uses a condom correctly every time, there's about a 2% chance of pregnancy. So it's actually a pretty reliable method. However, with typical use, about 18% chance. So you can see that just with education on some of these strategies, so just for your future practice, if you have patients who would prefer to use a barrier method like a condom, there are good education points that might apply to those people that would help them to have that particular product be more reliable than what the general population experiences with it. You can see that really, if you're looking at something that's a sure bet, the only thing you have are, well, there's sterilization methods, of course, but those are a little extreme for most people, especially if you just want to put your fertility on hold and maybe have children later, or maybe you've had a child and you want to wait a few years till you have another one. You certainly don't want to undergo one of these options. So your real options for taking the compliance issue out of play completely would be the implant, the etonogestrel implant, or the intrauterine devices, which we'll talk about later. So those, of course, don't require anything to be done once they've been inserted into the human, and then that's just how they work. So a professional puts them in, and then you don't really have to worry about them. Very, very low chance of failure with those, and extremely reliable. Okay, let's talk about the different components in combined oral contraceptives. So you have the estrogen component. Estrogen component is pretty straightforward because it's only one drug. You're only going to see one different kind of estrogen, and it's ethinyl estradiol. It's been around for quite a while, and again, it's pretty much in every oral contraceptive. Standard dosing is around 30 to 35 micrograms. I don't care that you know that, but the important part about giving you a frame of reference is that they do have multiple products with varying amounts of estrogen. So you'll see different oral contraceptives branded as, usually they'll say like a low after them. So for example, there's an orthotricycline regular, and then there's an orthotricycline low. The regular has 30 or 35 micrograms, I can't remember. The low has a slightly lower amount at 25. And then there's even lower ones like low estrin, which is already, low estrin's already kind of a low product anyway. You see the branding and these marketing geniuses at play here. And you've got 10 micrograms in that one. So that's one of the lowest ones. I think that might be actually the lowest one on the market as far as estrogen products goes. And we'll talk about why that's important here in a second. The progestin component, there's a lot of different ones on the market. There's I listed several common ones there. However, there's many more than that. And if you're curious and looking at a pack of birth control or something like that, and you're wondering, gosh, I can't remember which one's which, well, you can see that it's not the one that's ethinyl estradiol, right? So if you're looking at the combination product, it's like orthotricycline low. What does that say? Oh, norgestimate / ethinyl estradiol. So then you know which one the progestin is. Progestins all have some residual androgenic activity. They're derived from testosterone. However, it does vary. There's actually one, drospirenone, that's marketed as being anti-androgen, which I don't know if that's technically correct. It's probably more just very, very low androgenic activity, if not zero androgenic activity. So that could affect the side effects people are having as well, depending on how androgenic their particular progestin component is. And we'll come back to this in a little bit. These are the different generations. Again, not really that big of a deal, but as things get newer, generally speaking, the newer ones have less androgenic activity, but that's not always the case. And here's, again, the level of androgenic activity. Low, again, drospirenone is sometimes marketed as anti-androgenic, but it's just technically a really, really low activity of androgen. Okay, let's talk about the mechanisms quickly. Estrogen, going back to this quickly. So again, this is ethinyl estradiol. As far as mechanism of action, you're looking at suppressing hypothalamic gonadotropin releasing hormone, or GnRH, and pituitary gonadotropin secretion. Basically what this does is you inhibit mid-cycle LH surge, and ultimately you're preventing ovulation. That's sort of the main mechanism behind how oral contraceptives work. If you take a medication with a hormonal contraceptive without an estrogen component. So there is one product out there that's a progestin only pill. It's not quite as effective because it's not going to reduce this. However, there are other mechanisms that progestin works on that are synergistic with the inhibition of ovulation. However, inhibition of ovulation is kind of like what most people think of when they think of birth control mechanism, and remember as like sort of the hallmark. It basically prevents an ovulation from happening. Suppression of ovarian folliculogenesis, so you actually have some other mechanisms there, and then suppression of ovarian steroid production too. So all these things kind of feed back into the overall disruption of female fertility, and estrogen again has several mechanisms, but the big one being preventing ovulation. Progestin adds a couple mechanisms too. So you have effects on the endometrium directly, which renders it less suitable for implantation. So even if there is ovulation and there's a fertilized embryo, it is very unlikely to be able to implant, and eventually the endometrium will atrophy over time, making it difficult for any type of fertilized egg to actually implant and develop into a fetus. You also have alterations of the cervical mucus, which make it thicker and decrease permeability to sperm, so that sperm can actually get through the area. And then impairment of normal tubal motility and peristalsis as well, so eggs have a more difficult time getting from the ovary into the uterus. So again, multiple mechanisms. I think it's interesting because a lot of people think, well, it just prevents me from ovulating, but actually there's a lot of different mechanisms going on with oral contraceptives. And so all these things work together. You think about all the different think we just talked about 6 or 7 different mechanisms. All of them together make it a very, very effective product, and that's why when taken regularly, it's difficult, if almost impossible, for most people to get pregnant while on an oral contraceptive. We all hear stories, right? So-and-so got pregnant while on birth control, or got pregnant on their IUD, and I'm not going to debate that, but it's very, very rare. We'll put it that way. And I like this picture. It's like, no, the birth control pill doesn't actually go there, believe it or not. That's my little joke for the day. I I actually had a patient once who it was like when I was in my first year or as an intern or something like that. I was working at a pharmacy, and I listened to a pharmacist counsel, and so I didn't really talk to her, but peripherally I got the experience, so that was educational at best. But she was actually inserting her tablets vaginally because that's where she thought they were supposed to go, because no one really told her otherwise. And so there you go. Sometimes people might think about it that way, so I'm just throwing that out there. That's not totally all the realm of possibility, so it's kind of my joke for the day, but also a real world example. I've also heard, well, I'll talk about that later, sorry, I'm getting ahead of myself. Everybody has probably seen this in a health class or a biology class you've taken. I'm not going to go through it again. Certainly interesting as far as hormones go and manipulating hormones, and what we're trying to do here to prevent ovulation and to prevent a fertilized egg from taking a hold and developing into a fetus. That is the goal of oral contraceptives. And again, we talked about the different hormones we're manipulating. So if you want the visual chart, here it is. But again, I'm not going to go through this. All right, starting an oral contraceptive. This is always a little bit more confusing than I think it has to be. There's a couple options here, and you can follow this flow chart. So first day of last menstrual period. If it's less than 5 days ago, you can start the method today and use backup method for the first week. If it's more than 5 days, you want to get a pregnancy test, make sure it's negative, and then do they have unprotected sex? When was it? And then you have other options here. And then does the patient want the new method now? If it's more than 5 days ago, blah, blah, blah. So anyway, you guys can go through this a little bit on your own. The point is that there's multiple different ways to do this, but generally speaking, they all kind of follow the same strategy. And most commonly, if you're at a loss and can't remember all this, essentially backup for 7 days is never a wrong thing to tell somebody to use. There's some other options too that are more streamlined and common. So some people will just recommend something called the Sunday start, which is starting the pill on the first Sunday after menstrual period begins, and then using backup contraception for 7 days. Very easy way to do it. It lines up with the way that the contraceptive pill packs work, and so it's logical and it makes sense. There's a first day start too, which is to start your pack on the first day of menses, and then you don't actually need backup contraception, technically. So, again, depends on what the person wants to do. But the Sunday start's probably one of the more common ones, again, just because it's nice to start, at least I think from most people's perspective, if you're a little OCD like me, not that I take oral contraceptives, but you know what I mean, start on your Sunday so that you're at the very first day of the pack, and then you can kind of work your way across. Whereas if you're starting kind of in the middle, I feel like that sets people up a little bit for failure from a compliance perspective. Not totally, and most people obviously can understand that, but there's always that little risk that you started in the middle and then you kind of mix up where you're supposed to go from there. And this slide I threw in here just to see if you want to compare how you might start a different type of product that's not a combined. So here's your combined hormonal contraceptive. And then the other options here and what you might need to do in case you want to compare and contrast those. I talked about tablet packs. I'm sure most people have probably seen one of these at some point in their life, but in case you haven't, there are lots of different ways that companies package them. Some are much more, I shouldn't say complicated, but like these circular ones kind of have this little dial in the middle you can set, so that might eliminate your starting on a different day type of thing. Issue with that is you can set the actual day of the month there, which is kind of nice. Otherwise, most of them, like the generic ones that are out now, are pretty common to see just these sort of basic calendar setup packs. As far as other instructions, normal use, the recommendation is to take the same time every day. Don't miss doses. Hormones don't last very long in the body. So if you, for example, take it in the morning on one day and not until the evening the next day, you could have a large enough gap in blood concentrations that you end up with a missed hormone coverage, which can ultimately possibly lead to ovulation. So some people can actually get pregnant just from taking things on the opposite ends of the day. So it is really important, actually, probably one of the more important medications to be consistent with to make sure it's fully effective. If you do, again, kind of fluctuate your time of the day, you take it a couple hours, probably doesn't make a difference. But again, like 12 hours or something, that might make a very substantial difference in the effectiveness of the product. Missed pills is a question that probably everyone will get, and just by nature of being in healthcare, a friend might ask you this too, so it's probably a good idea, if you don't know this, to have somewhat of an idea of this. So missed pills, if you miss a single pill, you just take it as soon as you notice it, even if that means taking 2 pills together. So let's say you take it every day in the morning, and you look and it's Tuesday and your Monday one's still in there, like, oh shoot, take them both at the same time. You don't technically need additional contraception. I know I just told you there's a risk, and yes, there is a risk. So certainly if somebody was really concerned, they could obviously use like a condom in the meantime, because there's no problem with that, right? So there's certainly, if the patient has that extra layer of concern and they want to double cover themselves from a contraceptive point of view, that's no problem, of course, but there's not technically a very high risk with that. And again, this fluctuation daytime isn't a high risk either, but again, it's recommended, and it certainly decreases the overall effectiveness of the product. If you have 2 or more missed pills, you want to take one of your pills as soon as you notice, and then just continue your regular schedule. And if the pills were missed during days 15 to 21 of a 28-day pack, you finish the hormone pills, start a new pack, skipping the placebo altogether, and use backup contraception for 7 consecutive days. So again, backup contraception, continue the pack. Extra pills, so let's say you actually took an extra one in a day, just resume your normal schedule, don't skip a day, and just make sure your patient gets their product refilled so they can continue it without missing a dose. Usually not a big deal. And people, if they take an extra dose of hormone, probably won't notice much. You might see some breakthrough bleeding or spotting more so than you normally would, but that's probably the biggest side effect people would experience. Return of menses within 30 days after stopping the pill is usually pretty common. If not by 90 days, you may need treatment for amenorrhea or just to follow up with provider. So that's probably the counseling tip. You should get your regular period back within 30 days, and if you haven't gotten it in 3 months, let's talk again. There are a couple different types of oral contraceptives, and generally they're basically the same thing. One is a 21-day and a 28-day cycle. The 21-day packs just really don't have any placebo, so it's just active packs. So some people can decide to just, if they take a 21-day pack, they could just get their period and start a new pack, or they might just take it continuously and skip menses altogether. So they just take 21 days, another 21 days. And in fact, some products are actually marketed as multiple 21-day packs. So you might have like an 84-day pack that has no placebo pills, and then a patient might take 7 days of placebo, or just get their period naturally and then restart their next pack. So that's an option too. Technically, you can just take oral contraceptives without taking placebo pills for a number of times, but generally can cause some breakthrough bleeding over time just because of the atrophy of the endometrium over that long of a period of time. But it might work for some patients. And then there's monophasic and multiphasic products. So a monophasic it's kind of like what it sounds. You just have the same dose of hormones throughout the entire pack. Multiphasics have different varying hormones. So like, I'm just going to go back to this picture quick. So you can see this is a multiphasic pack. You have different doses with the different colors. And so like ortho-tricycline, it says it in the name, right? Tricycline. Usually it's a fixed dose of estrogen, and the progestin products are varying. And essentially the point is here you give an effective product still, but overall your steroid dose is lower, so ideally you'd have less side effects because of that. There's actually no proven clinical benefit for this. However, some patients might tolerate it better, so it might be worth a shot if your patient's having some side effects on a standard monophasic pack to try a multiphasic. But again, there's no real proven difference between them. Side effects, they vary, and a lot of patients will tolerate oral contraceptives with very minimal side effects, but here are some of the more common things. Common, and I should say less severe or maybe less problematic, something like that. You guys kind of get what I'm saying. These are the less concerning side effects. So with estrogen, giving estrogen as a product, so ethinyl estradiol is going to cause bloating, nausea, and breast tenderness. These are usually seen at the beginning of starting oral contraceptives, and they usually subside over a couple months once the patient gets used to having it, the new hormone in their body. Venous thromboembolism is by far the biggest risk when it comes to oral contraceptives. So higher estrogen doses is what causes you to be at risk for VTE. But risk is prevalent with either a low product or a high dose product. It's really not that significant of a difference. As far as the population goes, older and heavier women are generally at higher risk than younger and smaller women. Thrombophilia disorders, like people with factor V Leiden, for example, are at higher risk. And if you look at it as a whole group, the risk is quite low, especially for younger, healthier women. You're looking at about 3 to 13 people per 10,000, which is significantly lower than people who are pregnant or in the postpartum period, where risk is quite high compared to the general population. So, you could maybe make an argument that if you're on a low estrogen product, it might be kind of on the lower side of this, high estrogen product on the higher side, but overall you're still kind of within that realm of what's expected for being on oral contraceptive, which is still a low risk, but it's slightly higher than people who wouldn't take contraceptives at all. As far as cancers, there is thought to be a slightly increased risk of cervical cancer and mixed data on breast and liver cancer. Weight gain. Inconsistent data. A lot of people say, I gained weight on the pill, but actually there isn't a lot of good clinical evidence to support that people do gain weight. Some people might experience some fluid retention, but again, that should go away over time. Breakthrough bleeding is another really common side effect, and it just reflects the breakdown of the endometrium. Usually you're looking at missed pills, lower estrogen doses. So if somebody has a really low product, a low estrogen product, they're going to see less stabilization of the endometrium, which is going to cause more breakthrough bleeding. Extended regimens can also cause that too. Again, if you're skipping the placebo pack regularly, that can cause breakthrough bleeding over time. So that should give you a little bit of a clue as to what you can do to successfully treat somebody who is having breakthrough bleeding. Maybe they just started oral contraceptives, they're having a lot of breakthrough bleeding, it's just not working well for them. Increasing the estrogen dose, assuming you're on a lower dose product, is something you can try, and that might help with that particular side effect. Other types of infarctions like stroke and myocardial are very, very low risk, but for stroke example, like it's really low in women under age 35, slightly higher if you're over 35, but still pretty low. And if you're over 35 and you smoke cigarettes, it's really, really high. So compared to the general population. So that's a big no-no. Cigarette smoking and oral contraceptives is a big problem as far as stroke risk. And then higher risk with migraine headaches with aura at any age. So we'll talk about some specific contraindications, but sort of gets your wheels in your brain rolling on what might be not recommended as far as patient populations for using oral contraceptives. Myocardial infarction, their studies aren't great, likely very low rates and no significant risk there. I mentioned the anti-androgens and the controversies associated with them. So I shouldn't say them. There's only one on the market. It's drospirenone. Drospirenone's in 3 different products, though. So there's Yasmin, Yaz, and Bayaz. Yasmin and Yaz are generic now, and Bayaz, I think, is still brand name. Yaz is just a lower estrogen version of Yasmin. And Bayaz is the same thing as Yaz. They just added like a folic acid derivative to it. You might wonder why they did that. Good question. Just to get an extended patent is the real answer. My cynical drug company hat on right now. But what the drug company will tell you is that if a patient is taking Bayaz and they might want to stop taking it in order to get pregnant, they'll already have a good amount of circulating folic acid supplementation on board already. Now, the other way you could do that, a lot cheaper, is to take generic Yasmin and just take an over-the-counter folic acid supplement daily. If you're thinking about, well, I might stop my birth control in 6 months, so we can try and get pregnant, I'm going to supplement with a prenatal. That's pretty straightforward, right? You don't need a fancy, really expensive prescription product to do that. So I don't really understand the point of that. Again, I think it's just some drug company getting creative to extend some patent and keep a brand name product on the market. So the controversy with these, outside of that weird folic acid thing, is that they're associated with a greater VTE risk when compared to levonorgestrel. So the risk is still pretty small, so we're still within that 3 to 13 per 10,000, but it's on the higher side. It's also significantly lower than during pregnancy. But the problem with this is it's a really popular product, the Yaz and Yasmin generics and such. So they've gotten a lot of press and people probably requesting them or wanting to take them because they market them specifically as causing less bloating, acne, weight gain, and helping with PMS type symptoms. So they have this extended marketing system that's designed to promote them as being less side effect producing than other products out there, and that's basically because they don't have that androgen component, which is what is causing the bloating, acne, and weight gain for most patients. And anyway, so a lot of people like this product because of that, but at the same time, there has been some evidence coming out that shows that people might have that slightly greater VTE risk, so that's something to caution people on and educate people on. If you wonder so I talked about the side effects and why they're important in certain populations, but these are the actual contraindications. So if you're over 35 and smoke more than 15 cigarettes a day, contraindicated. That's one of the biggest ones. So if you have a patient, that's probably going to be pretty common to see. And then everything else, history of VTE, history of some sort of ischemic episode, uncontrolled blood pressure. If you're on medication and your blood pressure, oh my gosh, if your blood pressure is below this, then you're fine. You can be medicated to control that part of it. Migraine with aura, breast cancer, cirrhosis, a bunch of other stuff on here. Drug interactions. These are CYP metabolized, and so enzyme inhibition is usually not a big concern, though. However, things like azole antifungals and grapefruit juice may actually cause higher serum estradiol concentrations. Again, probably not enough for a patient to experience side effects. Enzyme induction may decrease efficacy, so you probably would want to avoid oral contraceptives if somebody was on one of these medications regularly. These aren't very common medications for most patients, so probably not a huge issue overall. Antibiotics is probably one of the biggest ones that comes up. Very much okay to use, although there is some controversy, and the reason why is all sex hormones undergo enterohepatic recycling, and we rely on our GI flora for this process. So anything that's going to disrupt GI flora may actually diminish the ability of the body to recycle and reabsorb those sex hormones. And so if you're wiping out GI flora on an antibiotic, you have less ability to be able to reuse those steroid hormones. This has actually not been proven clinically. It's a theoretical interaction, and for the most part, we don't get too concerned about antibiotic use and oral contraceptive. However, it's never a bad idea to suggest backup contraception. I think that if you wanted to be careful, that's probably the best way to do it, because you don't really know for sure. And again, studies will say that this doesn't really matter. They have looked at this clinically and shown it's probably not a big deal. But again, there is that little risk there that would make me maybe question it a bit and want maybe some backup just in case. Other options. St. John's wort is we talked about this in depression. It's an over-the-counter herbal, may induce the CYP system, and HIV drugs can induce the CYP system. So making sure that there's no interactions there if your patient falls into one of those categories. The NuvaRing and the Ortho-Evra patch are two non-oral hormonal contraceptive options. They're both combined, as you can see, with ethinyl estradiol and then a progestin component. NuvaRing is used intravaginally. You can you put it in for 3 weeks, and then 1 week without. Sorry, this is a little confusing. You just insert it once for 3 weeks. You don't put one in every week. And so basically you have one that works for a 28-day cycle. Then you remove the product. You rinse with, if you remove, well, you'd remove it after this and throw it away. You don't put it back in. But let's say during this 1 month time period, you want to take it out. Some people might like to take it out, or it might actually slip out in some patients, but some people might like to take it out if they're potentially having intercourse or something like that. You'd remove it, and you can actually rinse it with warm water and put it back in if it happens to fall out. And you actually get a 3-hour time window that doesn't diminish the efficacy of the product at all. So again, if you want to take it out for an hour or two for whatever reason, you can do that. There is controversy with this one, kind of like the anti-androgens of VTE, high end of the risk. Merck is the company that makes it, and they actually had some large settlements associated with this particular product. So kind of another one that's come up as being higher risk, but still lower overall and much lower than pregnancy. Ortho-Evra is a low-dose estradiol product. However, because it's transdermal, the overall exposure is much, much higher. And this one, again, has, like the ring, has a bigger increased VTE risk associated with it. And there are some lower ethanol estradiol patches in development, but I haven't seen them come to market yet. You put one patch on each week for 3 weeks, and then one patch week free, and then that's the cycle that repeats. So this one's probably a little less convenient because you have to remember to do something every week, which studies say patients just generally aren't good at doing that. Not recommended for use in patients over 198 pounds. The absorption with extra adipose tissue is just not well studied, and efficacy is not guaranteed in heavier patients. In case you're wondering how the NuvaRing is inserted, it goes up and goes kind of right around the cervix, and then you have the size of it. It's like this. It's very flexible. It just looks like kind of a plastic ring, and there's drug in it that kind of elutes out. You don't get drug on your hand. By touching it, you can't wash the drug off of it. It just comes. It's designed to come out over time. And the Ortho-Evra patch can be worn in a number of discrete locations. Non-oral hormonal contraceptive continued. You have Depo-Provera injection. So the Depo-Provera injection is a once every 3 months IM shot. It actually has no estrogen component. It has very high weight gain associated with it, actually, compared to any other contraceptive option out there. It's relatively inexpensive, so you might see it used in patients who are paying cash or something like that, but compared to maybe some of these other options. IUDs, the most common ones are hormonal, but there is a non-hormonal option that I threw in here just because it fits with the IUD category. So IUDs, most of them are levonorgestrel releasing. There's 4 different brands on the market: Mirena and Laletta, and then Kylena and Skyla. And they just vary in order of decreased levonorgestrel release. So you have Mirena was one of the first ones on the market, and so it's the higher one. And Laletta is like a Mirena generic, technically. It's a very slightly lower dose than Mirena. And then you have other ones that have different varying amounts. They all basically do the same thing. There's no real recommendation, as far as I know, between the different ones. Very few contraindications to using an IUD, other than if you've just had a baby, you have to wait until the uterus kind of gets back into shape before you can insert it so you don't actually perforate the uterus. Other than that, there's virtually no problems with contraindications. Significant reduction in menstrual blood loss and dysmenorrhea. 75% of women will still actually ovulate on this product. Just fertility is very difficult, if not impossible, due to implantation and also cervical mucus not allowing sperm permeation. It's approved. These are all approved for up to 5 years of use. So for patients looking for a long-term, somewhat long-term, I should say, hormone option they don't have to worry about taking every day. These aren't cheap. I think they probably cost around $1,000, and then somebody has to put it inside the patient, so you have to have some clinic time associated with that. But once it's in, and then you don't have to worry about it at all. So certainly a really nice option for patients, again, looking for several years of contraception that they don't have to worry about taking pills and adjusting doses and remembering refills and forgetting and things like that. very attractive option for that reason. Also, as far as contraindications go, if you have patients who, for example, get a migraine with aura and really want a birth control option, this is one what they could actually use versus the oral contraceptives that's contraindicated. Copper IUDs don't elute any type of hormone, but they can be left in place for about 10 years. Patients generally get heavier menses with them. They are very slightly less effective than the levonorgestrel, but they are still quite effective, and they are directly ovicidal too, which can be depending on how the patient perceives the mechanisms of their birth control and how acceptable that is to them. They might want that or not. This is my weird picture. I did this a long time ago, and I was looking at trying to find a good size comparison for how big an IUD is, and this is the one I ended up choosing. So sorry, it's really weird. It's kind of funny. But anyway, so IUDs are inserted. There's these little strings, not really strings, they're kind of wires. And once they're inserted, they're usually trimmed small so that, like, for example, during intercourse, a partner is not going to get poked with a wire. And then they can be removed by a provider. Sometimes people will pull them out themselves. It sounds extremely painful, but I've seen people in the ER with that before. Certainly, if somebody wants to get it removed, highly recommend they go to a person who's trained to do that. These two, if you're wondering how they get in there at all, these two arms fold down. It's kind of like the ship in the bottle thing with the masts, and then it goes in, and then they kind of, I guess there's some sort of little device that pops it open so that it stays in there, and then it opens up like an umbrella. Kind of a cool little invention, I think. Anyway, here's your other types of IUD mechanisms here. All right, what about non-contraceptive uses and benefits you might get with these medications? Certainly, people take these not just for contraception. So, for example, hyperandrogenism, usually due to polycystic ovarian syndrome, people might respond well and get some of their side effects managed with one of these products, especially something with lower androgen, like a low androgen product, or even a quote-unquote anti-androgen like drospirenone. Dysmenorrhea, menorrhagia, hypothalamic amenorrhea, so all types of menstrual disorders. This can help regulate that particular process. A couple other things even indicated as far as things like acne. We talked about some increased cancer risk, but actually there's some decreased cancer risks as well. Patients who are on oral contraceptives for a long period of time have significantly decreased risks of endometrial, ovarian, and colon cancer. Use during lactation. So in the postpartum period, hormones are excreted into breast milk, so you might get some absorbed into the infant, which could be problematic potentially. But the bigger reason why we generally don't use anything with estrogen in it in the postpartum phase for breastfeeding women is because of estrogen decreases milk production. And so usually patients are going to use a barrier method, or they might use one of these options. So progestin only, Depo-Provera is an option, or IUDs would be the option, again, after 4 to 6 weeks postpartum. Emergency contraceptive, so people who have recent unprotected intercourse or recent contraceptive failure and are concerned about an unplanned or unwanted pregnancy. High-dose progestin is usually was the original one. That's Plan B, levonorgestrel. What it does is it delays ovulation. Couple problems with this: it's much less effective in overweight or obese women, and it has substantial diminishing returns over time. So after 72 hours, you lose efficacy significantly. So it's really only effective like within a very short time period after taking it. The nice thing is this product is over the counter, so there's that. Ulipristal is Ella, or Plan C is what some people call it to be funny. Ella, or Ulipristal, is actually a little bit different. It's a newer product, not newer. It's been around for, I don't know, probably at least 8 years now, but somewhat newer, maybe 5 years. Anyway, prevents progestin from binding to the progesterone receptor, which delays ovulation. So it's actually not hormonal. It's a receptor modulator, and it has data showing efficacy for up to 5 days without diminishing returns, and its data is better in patients over 80 kilograms. So for that reason, we always prescribe this. So the most in the ER, I don't see this a lot because people don't usually come to the emergency department for this. However, people do come to the emergency department post sexual assault. And in those unfortunate circumstances, they usually will take emergency contraception as well. And ulipristal is the one we give just because, again, efficacy is better and it works better in heavier patients. Copper IUD is an option too. So if a patient wanted an IUD, you can insert a copper IUD. It's 95% effective within 72 hours. Then, of course, it provides years worth of contraception too if the patient wants it. Not really common, but it is an option. NSAIDs is a less desirable option, but there are some NSAIDs out there that can work to inhibit fertilization as well. Or not inhibit fertilization, but maybe implantation would be the better word on that. All right, that's it for contraceptives, and we'll move on to hormone replacement therapy here. Oh, sorry, let me just jump back to this really quick. I did talk about Plan B being over the counter. Ella does require a prescription, so that's probably the biggest difference in its barrier. Like, why wouldn't more people want this one? Most people probably would if they knew the differences. But again, that's maybe at some point that'll change, but that's where we're at right now. Okay, anyway, let's talk about menopause and hormone-related treatments and some non-hormone-related treatments for menopause. 95% of all women will experience menopause between the ages of 45 and 55, and officially defined as cessation of menstrual periods for 1 year. Treatment directed at symptom relief. So there's 3 major kind of axes of symptoms: vasomotor, which is what we describe as hot flashes, night sweats, sleep disturbances; vaginal atrophy, and mood swings. Symptoms most prominent during the last 2 years of the perimenopausal period, and then usually they wane as menopause completes. So hormone replacement therapy during this time is an option, but there's a lot of risks and some benefits as well. So hormone therapy does play an important role in symptom management. It's not generally recommended for prevention of chronic diseases associated with menopause, but more or less to treat the symptoms. So we're going to talk about some of the benefits to it. Like we already talked a little bit about estrogen and osteoporosis, so that's sort of where I'm getting at with that. Giving hormones to replace the lost hormones during menopause is a really effective way to treat the symptoms of menopause, but there are risks associated with it. So who do you treat? Usually perimenopausal women with moderate to severe vasomotor symptoms who will need systemic hormones. People also would have to have no history of breast cancer or cardiovascular disease. If somebody just had vaginal atrophy, there are a lot of local vaginal-only products that are like estrogen-containing creams that work well for that purpose. The benefits of estrogen. So estrogen relieves genitourinary atrophy, vasomotor instability. So again, improving sleep, reducing hot flashes. There's osteoporosis benefits there that I've got. There was some thought that there was cholesterol or heart disease benefits, but actually it hasn't been shown to do that at all. There are a couple of big studies that came out that shown there's no real benefit to estrogen in those areas. It can help stabilize some of the mood changes associated with waning hormones, and will help with vaginal atrophy and decrease intercourse-related pain, and therefore help with sexual function. Risks of estrogen. So those are the benefits. Let's talk about why people might not want them. Endometrial cancer risk increases with unopposed estrogen. So in a patient with an intact uterus, we really want to avoid any type of plain estrogen product. In those patients, you can give estrogen, you just have to have progestin alongside of it. Best to avoid, if somebody has a history of endometrial cancer, you want to avoid estrogen completely. The risk of breast cancer is uncertain with unopposed estrogen, but some people think relative risk might increase by about 25%. Generally, it's recommended to avoid that avoid estrogen as well if you have a history of breast cancer. Cardiovascular outcomes, we're going to talk about those separately in a minute. General adverse effects, we talked about that it's the same thing as oral contraceptives. So here are the Women's Health Initiative outcomes, which is a big, I think I've mentioned this before. The WHI was a big meta-analysis that looked at a number of women's health-related issues and treatments that were specific to women and what kind of benefits and risks they would have. So for steroids specifically, so this was trial looked at conjugate estrogens, progestin in women ages 50 to 79, prevention of CHD. And then it looked at, was there any benefit of giving these people? So this was actually combined hormone replacement, not just plain estrogen. And so you had heart attacks increased, breast cancer increased, strokes increased, blood clots increased, hip fractures, colon cancer decreased, and dementia actually increased pretty substantially. So there was actually this trial that said, well, maybe in older women, if we gave them hormones, maybe it would decrease dementia, and actually didn't at all. So that's why we don't really use hormones that much if we can avoid it. And basically, like what I said earlier, if we're going to give hormones for somebody in the perimenopausal period, we're going to give them for vasomotor symptoms that are severe, and then we're going to try and keep them on the hormone as little time as possible to get them through it and through menopause, and then we would take the hormone away, because there really isn't much benefit in continuing the hormone after that. In fact, you end up increasing risk of a lot of different things. These are all relative risks, so the absolute cases quite low if you look at this, but still, I mean, it's a risk-benefit thing, that there's no real benefit and the risk is there, so we don't need to give hormones if we don't have to. All right, so adding progestin to an estrogen regimen for menopause benefits. You decrease the risk of estrogen-induced irregular bleeding, protection against breast carcinoma, and enhancement of estrogen prophylaxis in osteoporosis. General effects are there, and unpredictable bleeding during the first. Remember, progestin causes atrophy of the endometrium, so you're still going to get that same side effect like you would with an oral contraceptive. Hormone therapy treatment options. There's a lot of options out there, a lot of delivery routes too, and all the products that are systemic will treat vasomotor symptoms, except anything that's just intravaginally, unless it's a ring of some kind, like a NuvaRing, will only treat, so like a vaginal cream doesn't absorb enough systemically to treat vasomotor symptoms. So if you have vasomotor symptoms that are severe, you have to use something systemic. Unopposed estrogen therapy, talked about this again. So if you have somebody with an intact uterus, you're going to want to use a combination product. That's the big take-home message here. If you have undergone a hysterectomy, there's no real reason to give somebody a progestin product. In fact, it'll probably just increase side effects overall. So a plain estrogen product in a patient who has hysterectomy history would be preferred in those cases. Here are the different estrogen products on the market. And there's combinations in here too. So you can see like oral estrogen progestin combinations here. You can see vaginal rings. So I think I missed. So this is where it gets a little confusing. I kind of misspoke, but I kind of said the truth, right? so like intravaginal rings, some of them do absorb systemically. For example, this fem ring does. However, these products are specifically the S ring only releases locally, so it really doesn't have, and again, inadequate dose to relieve vasomotor symptoms. So again, there are some things that are. So I kind of led you astray, but generally speaking, the topical products have lower amounts of estrogen in them, and they just, again, you're going to get some systemic absorption, but not enough to treat vasomotor symptoms. Overall, the doses of estrogen when it comes to treating menopausal symptoms are quite a bit higher than what we'd experience with oral contraceptives. And you can see most of them are different products, like estradiol. Some of them have ethinyl estradiol, but not all of them. So anyway, there's differences in the bioavailability and how much, generally speaking, you're going to see quite a bit more. All right, so we talked about unopposed estrogen. Other products exist out there are estrogen plus cyclic progestin, just like oral contraceptives. They look very similar in how they're designed. And there's continuous, cyclic, there's intermittent, and I don't really care these because they're all basically the same as far as efficacy goes, and it's going to matter as far as how the patient's going to respond to them and what types of side effects they might get and how you might tailor that. Monitoring for self-breast exams, mammographies, pelvic exams, and vaginal bleeding would be your main things here. Duration, again, like I said earlier, lowest dose, least amount of time possible. Check symptoms after 3 months into starting, and after a year, and once somebody's asymptomatic, you want to discontinue it. You limit therapy to 5 years. There really shouldn't be any reason for somebody to be on a hormone regimen longer than 5 years for menopausal symptoms. Some non-hormonal options. So this is going to come up frequently. Patients might read all of this on their own and figure out, wow, there's a lot of issues with hormones. Yes, there are. So what about other things? Selective serotonin plus or minus norepinephrine reuptake inhibitors have been shown to be somewhat helpful. SNRIs are probably the more common ones. Venlafaxine is the one I think of a lot is used for this, but SSRIs like fluoxetine, paroxetine, sertraline have all been studied and used for this treatment. Really, any SSRI or SNRI is probably okay because they all have the same mechanism, so there's nothing to say that one of these works better than another. It's just these 4 have specifically been studied. Generally, the only difference between using these for vasomotor symptoms versus depression is they're used at lower doses. Some of them have been rebranded. So, for example, there's Brisdel and Sarathem, which are rebranded different strengths of fluoxetine and paroxetine that are really expensive. Just prescribe the regular one. You don't have to. It doesn't matter if they get 15 milligrams or 20 milligrams of fluoxetine. It really doesn't matter at all. So just use the cheap one. Don't end up giving them a prescription brand name product that costs hundreds of dollars when there's a generic equivalent that costs virtually nothing. There's some herbal products out there too. Soy isoflavonoids, evening primrose oil, black cohosh, and bioidentical hormones. Bioidentical hormones you'd have to get from a compounding specialty pharmacy, and the other ones you can usually get as far as over-the-counter supplements. Others, clonidine, megestrol, gabapentin have been studied with limited efficacy and mixed data. All right, breast cancer, the final segment here. I'm just going to talk about breast cancer briefly because I know we already went through it, but there's a big hormone manipulation, kind of like with prostate cancer. Wanted to talk about that component of it. So breast cancer is the most frequently diagnosed of all cancer types, leading cause of cancer-related death in women, especially ages 40 to 49. Lots of things you can do for breast cancer: surgery, radiation, chemotherapy, but 1 in 8 women will develop invasive breast cancer over their lifetime. Very difficult disease to treat in advanced stages, but early detection survival is really high. So that's why, because it's so common and because it's easy from a relative term, if you compare it to some other cancers, to detect and to treat in early stages. We're pretty aggressive about awareness and promoting that during physical exams and things like that. So stage 1 and 2, small tumors, no lymph involvement. Surgery alone is usually going to be an 80% cure rate. You don't really have to use any medications. Occasionally, they'll manipulate hormones for 5 years after that, which involves estrogen, estrogen plays a major role in hormone receptor positive breast cancer. And tamoxifen is the medication that we're usually going to use. It's a selective estrogen receptor modulator, so it binds to tumors and other target tissues, decreases DNA synthesis, inhibits the effects of estrogen, and competes with estrogen to binding. So if you remember back to our cancer lecture, we talked about the cell phases. This is going to cause cells to accumulate in the G0 and G1 phase, and they can't continue to produce produce new cancer cells. It's not cytotoxic, but it is cytostatic, so it stops the tissue from growing, the tumor tissue. And it's quite cheap as far as chemotherapy goes. Tamoxifan's been around a while. It's really affordable. So for that thing, that's actually kind of nice. Most chemotherapies are super expensive. Side effects, you're going to expect some of this stuff as an estrogen blocker. The idea here is that you modulate some of the estrogen in certain areas of the body and not in others, but that's really hard to do. So you end up with possible other effects too, like blood clotting risk, increased uterine cancer, even though you're having some other positive impact from it. Other hormone manipulation, aromatase inhibitors, just like with prostate cancer. So these prevent peripheral conversion of androgens to estrogen, and contraindicated for your premenopausal women with intact ovarian function because increased estrogen function due to negative feedback, unless you're okay with ovarian suppression potentially, but that's essentially what's going to happen. The examples are listed there, about 15 to 20 bucks per pill. These are not cheap like tamoxifen. There's not really a lot of data to start, say one's better than the other, so you kind of pick whichever one you want. Usually what you'd do is you'd start this after your tamoxifen is completed, if you're going to start it at all. It's not a guarantee in any patient, but it's an option. It's probably depending on how high risk the patient is and the oncologist's general treatment preference. Side effects, higher cardiovascular osteoporosis risk, and high incidence of myalgia and joint pain with these medications. There's some other things here that I'm not going to go through in detail because they get a little less common. There is a estrogen receptor antagonist called fulvestrant, which is a newer medication. It's an IM injection once a month. Slow down tumor, inhibit tumor growth, stop tumor growth. So there's some other options outside of tamoxifen, but tamoxifen is still probably one of the more common ones that's used. Stage 3 and 4 is metastatic. Just like most metastatic cancers, it's extremely challenging to treat. Often you're looking at palliative. There might be surgical options or more broad spectrum chemotherapy, but that's, again, it's difficult to treat patients with those particular diseases. So that's it. As far as knowing things for the cancer section, I would just be able to recognize aromatase inhibitors and know a little bit about tamoxifen and the general concept behind a selective estrogen receptor modulator. And that's all I have to say. So hopefully you enjoyed this lecture. We'll touch base on pregnancy and perinatal topics next week.